Thank you for attending today's webinar, Immunoserology Treponemal-Screening, Advantages of Using a Reverse Sequence Algorithm. I'm Lance Schlenker, the DSORN Product Manager for our Infectious Disease product line. Before I introduce our speaker for today, Dr. Tiffany MacKenzie, just a couple of brief housekeeping notes. In the lower left-hand corner of the speaker page, you will find a CE icon. After today's presentation is complete, you will be able to click that icon to register for your CE credits. Also, there will be time for questions and answers at the end of the presentation. If you have any questions, there is a question chat box that you can submit your questions, and Dr. MacKenzie will answer these questions at the end of the presentation. It is now my pleasure to introduce our speaker for today, Dr. Tiffany MacKenzie. Dr. MacKenzie is the Scientific Affairs Manager for DSORN, focusing on infectious disease. She came to DSORN with more than 10 years of laboratory experience. She started her academic career at the University of Wisconsin-Madison studying molecular biology and received her PhD in pharmacology at the University of Minnesota Twin Cities. Before coming to DSORN, Dr. MacKenzie spent 3 years in research and development at Access Genetics, LLC in Eden Prairie, Minnesota, developing HSV multiplex PCR assays. Please welcome Dr. Tiffany MacKenzie.
Thank you very much, Lance, for that kind introduction, and it is my pleasure to walk you through today Immunoassay Serology Treponemal-Screening assays that are available on the U.S. market, and especially the advantages of using a reverse sequence algorithm, and we'll go into great detail as to what that means. And as Lance said at the end, please submit your questions via the chat box, and please take note of any questions you might have. The whole presentation should take about 40 minutes, so we'll have plenty of time for questions, and we'll be live until 1 p.m. Central Time. So I hope that by the end of this presentation today, you'll take home with you a few key learning objectives, specifically being able to describe 3 methods, or a few of the key methods available for diagnosing syphilis infection. So both from like a historical standpoint and also just understanding some of the different chemistries and technologies that are available. And then also comparing and contrasting the 2 algorithms that are used in the diagnosis of syphilis, and also understanding how those weave in and how those fit in with clinical guidelines, specifically CDC or Centers for Disease Control guidelines, and also be able to, at the end of today, name 3 benefits of a treponema-specific IgM assay in identification in really for screening for syphilis. Okay, so syphilis has been long known to humankind. Some of the first cases reported in medical literature in the 15th century, and it was a particularly bad disease to have before 1928, which is because prior to that point, this was prior to the discovery of penicillin. And so the ongoing sort of one of the phrases affiliated with syphilis is "one night with Venus and a lifetime with Mercury," meaning that so before the advent of penicillin, mercury was the only treatment available, and as you can imagine, the side effects were almost as detrimental or toxic as potentially having syphilis itself. But in any case, shown here, I really like the TV show series Bones, and so being able to detail medical cases from the skeleton is interesting. So here you can see the 18th century English skeleton showing advanced syphilis because the T. pallidum can invade the bones in tertiary syphilis. And so just keeping in mind that this is long known to affect humankind, but yet it is still prevalent in our society today in the US and worldwide. And so here I'll come back, I'll revisit this schematic later in the talk as well, but I just wanted to introduce you, just so that we're all on the same page, as to just the general phases of syphilis, and then what are some of the hallmark symptoms affiliated with each stage. So assuming the beginning of the arrow, or the beginning of the timeline, is point of exposure to the bacteria T. pallidum. So there'd first be this primary phase in the first, so within 10 to 90 days of exposure is when the patient may first present with a chancre to their physician, his or her physician, and then and so the primary phase primary phase of syphilis roughly runs this course, and I'll go into more detail as to the timing of each phase when I go into the serology of antibody response to syphilis. But in any case, and then a patient would progress, assuming no treatment or no intervention took place. The patient would progress into secondary phase, and the hallmark symptom for that is this rash that presents on the palms and the feet. And so this can occur anywhere from like 6 weeks to 6 months post-exposure. And then after that point, still assuming no intervention, which could have happened a long time ago, it still could happen today. There were a couple case studies at the CDC STD Congress that a couple of us from DSORN attended in Atlanta last week, that there was a case study in Madison with a patient with tertiary syphilis where the T. pallidum had invaded his one of his bones and it was reporting knee pain. So it can still happen today. In any case, you progress to this asymptomatic phase, so this can persist for decades. And then eventually, and also the CDC groups neurosyphilis in this category. And then finally, the tertiary syphilis is when the T. pallidum may invade some of the major organs of the body, causing, such as liver, cardiovascular system, and a number of other, bones. So it could, left untreated, it could have very detrimental consequences. So of course we want to intervene. So, and that underscores the point of, just how prevalent or how many cases are reported per year. So this is pulled off the CDC physician self-training. I am not a physician, I am a scientist, but I still go to this website regularly as a resource to understand the clinical picture of syphilis in the U.S. today. And so you can see here that there is like an all-time low, let's say, of syphilis cases in the early 2000s, but it is very slowly increasing, and also it was obvious at these CDC STD conference that we went to a couple of weeks ago that there are outbreaks in especially MSM, men who have sex with men, populations throughout the country. And so definitely syphilis surveillance is a hot topic, especially for public health concerns and centers. And so you can see that it's the number of cases in thousands, so looking at the whole country. And then, of course, the prevalence, or the incidence, does vary state by state geographically as well. And so, for instance, if you picked out Kansas, you would see, 0.8 divided by 100,000. We're looking at an incidence of about 0.014%. And so, so generally speaking, the incidence is a little higher in the South and a little bit lower in some other states, at least what's reported. But you can see that looking at special populations, so for instance, MSM populations and pregnant women populations, you can see that in pregnant women the prevalence is even lower. So this is, previously we were looking at, say, 10 to 14 out of 100,000. This is, 1 or 2 out of 100,000. So this really underscores the point that we need, whenever you're designing any kind of assay, you want the sensitivity and specificity to be as high as possible. And sometimes you have to sacrifice one or the other depending on what you need to prioritize for the assay. But in this case, for pregnant women, you really want the specificity to be perfect. I mean, really good, because the prevalence is even lower than just looking at the U.S. population in general. And of course, we want the sensitivity to be there as well, which is enhanced by if you're looking for, like, let's say, G and M specific antibodies together versus G alone. But we will get to that in a moment. So I guess you can think of syphilis tests can be sort of divided into 3 different categories. One would be if a patient presents with a chancre or a rash and you want to investigate the specific lesion, how can you visualize it? How can you say concretely that this is being caused by T. pallidum? And one way to do that would be dark field microscopy, has been the historical way, but if any of us know who have worked in the lab long term, you know, any kind of microscopic technique, and here shown here is fluorescent microscopy, but any kind of microscopic technique is not amenable to screening or, you know, a high throughput reference laboratory, any sort of situation like that. So again, it is beautiful for you know, getting an idea of you know, what the organism, what the spirochete looks like. But also, it's important to note too that in contrast to, let's say, chlamydia, gonorrhea, T. pallidum cannot be cultured either. So this has also posed sort of a diagnostic challenge in terms of monitoring syphilis, medically speaking. And let's see here. Okay, so, and then, so like I was saying, the syphilis tests can be divided into 3 different camps. So yes, like looking, let's say taking a swab from the chancre itself, like a site-directed investigational test, which maybe today perhaps molecular testing will start to play in that field. And then there's also 2 different camps of tests. So there's treponemal tests and non-treponemal tests. So treponemal tests, including fluorescent treponemal antibody testing, adsorbed to a non-pallidum-Treponeme. This is more of a historical assay, but more currently looking at T-pallidum hematogglutination antibody. This is the acronym used in Europe. Here we use TPPA for hematogglutination antibody test, which have largely replaced fluorescent testing. But even more recent, so we'd be looking at ELISA-based chemistry, or EIA, enzyme-linked immunosorbent assay. Also, we could look at Western blot, again, if you're going to look at a specific antigen, maybe more for a research purpose. But again, Western blot is not really amenable to high throughput screening. But the most current or you know, state-of-the-art technology is chemiluminescent immunoassay technology, which is sort of an evolution of ELISA technologies, and I'll go into a little bit more detail later too about how it differs. And then, so these are some of the treponemal tests available, and the key distinction between these 2 camps is that treponemal tests specifically detect antibodies to T. pallidum, whereas non-treponemal tests detect non-specific antibodies to the cardiolipin antigen, which is released from the treponeme itself, or also other lipin antibodies released from damaged host cells. And so these tests include the Venereal Disease Research Laboratory test and the Rapid Plasma Reagent test. And these tests are still you know, used today for monitoring active syphilis infection in response to treatment. And so just to underscore that the CDC STD treatment guidelines state that the use of only one type of serological test is insufficient for the diagnosis of syphilis. So I don't want you to walk away today thinking you can only choose one or the other. If one of them is negative, and it's, you know, up to each lab which kind you use, but then you could report out a negative result. But if you want to confirm an active syphilis infection, you have to use a test from each of those camps or each of those types. So I mentioned that I would get into this a little bit earlier. So here is sort of a plot of the serological response of a patient exposed to T. pallidum. So you can see here that so the solid lines represent the T. pallidum-specific antibody response, and whereas the dashed lines refer to or are representing the non-specific anti-lipid response that a test like RPR would detect. So you can see primary syphilis, so generally speaking, is categorized within that first month of exposure, or more specifically, let's say the first 3 weeks. And from 10 to 90 days is when that primary chancre may present itself at the site of infection. But in any case, so 2 weeks post-exposure is when a patient would exhibit a TREP-specific IgM response. And this antibody titer is going to wane over time or decrease over time, whereas the TREP-specific IgG will present itself about a month post-exposure, so a little bit delayed after the M, of course, but once a patient has been exposed to T. pallidum, he or she is positive for life, so that's an important note to make. And then the dashed lines, you can see that for, so RPR, VDRL, they are detecting G and M antibodies to anti-cardiolipin. So the M would be detectable 5 weeks post-exposure, and the G would be detectable 6 weeks post-exposure. And these antibody titers will also decrease over time. I mean, the G for anti-cardiolipin may be positive, depending on the patient, for many, many years. But just keep in mind that if you want an answer, has a patient ever been exposed to T. pallidum? The way to determine that is through a TREP-specific IgG. Okay, so now revisiting that schematic that we had up earlier, sort of grouping stages of infection with hallmark symptoms. Now let's start looking at how is the performance of the non-treponemal test and the treponemal test at each of these stages. And so this is a publication or a book from 1990, so it's a little while ago. So, there's the same concept still applies. Looking at, so VDRL or RPR are looking at, they are the representing the non-treponemal tests available, and then FTA or TPHA are the treponemal tests available. So today it's still RPR is largely used for monitoring infection, live active infection, but largely today this like TPHA, let's say, would be replaced by ELISA or CLIA chemistry. But in any case, so at this primary phase, because of that delay in the anti-cardiolipin response, the non-treponemal tests are going to detect active syphilis infection only 75% of the time. But the treponemal-specific tests would be 90% of the time, or at least according to the results from this study. And then once you progress into the secondary or asymptomatic, or let's say secondary phase of syphilis, that's when all of those antibodies are definitely high. So either test, non-treponemal or treponemal, should detect with very high accuracy, high sensitivity, high specificity at the secondary phase. However, once you move into this asymptomatic phase or the tertiary phase, you can see that the non-treponemal tests start to only detect the active infection 3/4 of the time, whereas the treponemal specific tests will be positive 100% of the time. So this is because the G is positive for life. But one thing to note would be, so this really depends on, so this is assuming a non-treated patient. Because if a patient were treated and their RPR went down 4-fold, then this would drop off. So this is untreated patients. So just giving you an idea of the performance of non-treponemal and treponemal tests at each stage of syphilis. And then also just revisiting this idea that, of course, syphilis has long afflicted humankind, and so getting into a little bit of culture here, but you can see that this bust from Musée de l'Homme in Paris showing a patient with tertiary syphilis, and these gummatous or gummy tumors is another potential symptom. And then other tertiary effects, again, could lead to damage to internal organs like the brain, heart, liver, bones, eyes, and nerves. So it is pretty amazing that although this has been present in our society for many centuries, that it is still prevalent today, or is still present today. And so speaking to that, so what does the CDC say about screening for for pregnant women specifically. So syphilis screening is recommended by the CDC and Essential to prevent congenital transmission. And shown here is a public health poster from the 1930s. So again, this has long been a public health concern. And so the CDC does specifically recommend pregnant women be screened and counseled at least at that first prenatal visit. And just a little bit more detail, the risk of transmission to the fetus is highest during primary or secondary syphilis, but infection may occur during any trimester, and only severe cases are clinically apparent at birth. So it is really important to screen the expecting mother just because it is asymptomatic in the infant at birth. Okay, so we are convinced that we do need to be screening. Obviously, I'm not getting into MSM populations as much, or other public health testing centers, but taking pregnant women as an example population, it is apparent that it is, in order to be following clinical guidelines, we do need to be screening pregnant women. So the question is then, we have all these different tests available, specifically the non-traditional or the non-treponemal and treponemal tests. How do we perform these tests? That's the main question. And so to sort of read up on this, I pulled an article from the Journal of Clinical Microbiology, where two physicians were comparing the performance of the traditional or the reverse algorithm in their individual laboratories. So the physician practicing the traditional algorithm, which by definition is the first screening with a non-treponemal test followed by a treponemal test. The physician performing that was a physician at Mayo Clinic in Rochester, Minnesota, and then a physician advocating the reverse algorithm was a physician at University of Texas who was using the Bio-Rad treponemal immunoassay screen, and then following by a non-treponemal test. So, okay, so I'll get into this in a little bit later with the exact CDC guidelines, but I just wanted to introduce this concept to you. And just to also brush you up on, or bring us all to the same page as to what the rapid plasma reagent assay does. So it is still, even though it is perhaps not amenable for a large reference lab to do with large throughput screening, there have been cases where laboratory medical technologists are starting to be affected by carpal tunnel and other ergonomic sort of issues with this repetitive testing. And so although it might not be amenable to that, it is still definitely useful in terms of monitoring active infection. So you can see here that, and it is subject to interpretation a bit, but here on the upper left would be a reactive well, and then it is important that over time, so one of the posters we were looking at the CDC conference, that this is important for monitoring active infection, and you can see, you should see a fourfold or so dilution in response to penicillin treatment. And then over time, the patient should serorevert to a negative serology, negative result. Okay, so that's just an idea of how something like RPR works, and now a cartoon on how chemiluminescent chemistry works in general. I mean, this is specific to our assay, but any other manufacturers may have a similar design, but I'll just speak to our assay. So this is a one-step assay. It's the most simple one we have, actually. And so in this format, we have paramagnetic beads that are coated with the TPN17S antigen, a recombinant antigen. And so the key difference between, one of the key differences between CLIA, or chemiluminescent technology, and ELISA technology is that with these beads, so if you imagine this line is actually, I should maybe redraw this, but it is actually a complete sphere, so you're optimizing the surface area within your reaction module. And so as opposed to being limited to only the bottom of an ELISA plate well. So you're going from 2-dimension to 3-dimension. So that is one of the advantages of chemiluminescent technology in general. And so this paramagnetic bead is coated with the TPN17S recombinant antigen, and then assuming that the patient is positive for syphilis, and let's say in the secondary phase of infection and positive for both G and M, so the G antibody in green, the M in red, then both of those antibodies would have the opportunity to bind to the recombinant antigen. And then also in the same step, the TPN17S antigen is added, which is conjugated to an isoluminol derivative called ABEI. And so this is all allowed to incubate, and then the entire reaction, so with a magnet, you attract the reaction to the side of the module so that it doesn't wash away, but then you wash to get rid of any non-specific binding. And then after the addition of a couple of starters to initiate the luminescence, you report out an index value, which, so if it's greater than or equal to 1.1, this is determined to be positive, and if the value is between 0.9 and 1.1, that's the equivocal zone, so a retest should be done. And then if the index value is less than 0.9, then that can be deemed negative. And so just a little bit of background about our DiaSorin's chemiluminescent treponema assay was 510K cleared in 2006, and our predicate device that we compared to was the CAPTIA ELISA chemistry. So again, chemiluminescent chemistry, ELISA chemistry, at least in this case, they do perform very similarly. It's just the workflow that can be really different for the laboratory. And then our assay was cleared for screening, so syphilis screening and confirmatory use. So meaning you could use it as either the beginning or that initial test in the testing algorithm, or as the confirmatory test. FDA said it's fine for either way. And I just want to point out as well that in contrast, I'm the scientific affairs manager for a lot of our infectious disease assays, and so oftentimes, let's say when you're screening for measles immunity, the positive might say that you're protected or something like that, but here the positive says you need to supplement with a non-treponemal test. You cannot report out that the patient is positive, because it could be that they were positive for IgG, underwent treatment, and no longer have an active infection. So you really have to supplement with a non-treponemal test like RPR. And then, so revisiting now this the treponemal versus the reverse algorithm. So this is kind of the key part of the talk. And so this is pulled directly from the CDC Morbidity Mortality World Report from 2011, and we're all anxiously awaiting the next one to come out. So the CDC does recommend the treponemal screening algorithm. However, the reverse algorithm does have a number of advantages. But so pulled directly from the MMWR report, the CDC says that despite these recommendations for reverse sequence screening, the CDC continues to recommend the traditional algorithm with reactive non-treponemal tests confirmed by treponemal testing. So, but that said, I think that more testing can be done and is being done, and there are a lot of groups, including public health centers. Also, a couple of U.S. Army sites are switching to the reverse algorithm. So, slowly, more and more labs, if it makes sense for the lab, is looking at the reverse algorithm. And I just also want to note that the treponemal algorithm has been commonplace in Europe for over 20 years, and so DiaSorin, we're a European, or more specifically an Italian company, and so a lot of our we're always, it's kind of a fun part of my job too, is understanding how medicine is practiced in Europe versus US. But in any case, so the CDC does still, as of this 2011 report, was still recommending the treponemal algorithm, where you start with RPR, let's say, and then confirm with a treponemal-specific test, but they do not say that you can't do the reverse algorithm. So it's up to each individual laboratory. You are still abiding by guidelines as long as you perform your reverse algorithm in this format. So the CDC suggests starting with either ELISA or chemiluminescent chemistry. So EIA is the same as ELISA, or CIA is the same as CLIA. And then if that's negative, you can report out a negative result, no problem. But if that's positive, then you do need to confirm with quantitative RPR. And then if that's positive, then you can be quite certain that this is an active syphilis infection. If this is negative for some reason, which could be, then it is good for each individual lab to have on hand an additional sort of backup method. So like an agglutination assay would be a very nice method to have on hand, just to confirm active syphilis infection. And actually, the chemiluminescence studies that we have performed have shown that chemiluminescence does compare quite well to TPPA. Okay, so now for the remainder of the talk, I would like to really dig into the data of the performance of chemiluminescence versus ELISA versus RPR. And so this is a review from the Journal of Clinical Microbiology, referring to more specifically just showing that, let's say, in primary syphilis, yes, you can see that the sensitivity is lower than later in syphilis. But I'll show you these data. I just wanted to pull up that these data are referred to in a very nice review, but I'll show you the data in a more easy to read table. So, okay, so shown here, you can see that the performance of chemiluminescence, specifically chemiluminescence treponema sensitivity, is higher than RPR in treated or untreated patients. So you can see in untreated primary syphilis, RPR sensitivity was only about 62.5%, where comparing to ELISA, the CAPTIA ELISA, our predicate device for 510K clearance, was about 75%, whereas the liaison chemiluminescence performance was 100%. Progressing into secondary syphilis, the performance between chemiluminescence and ELISA was really almost comparable at that point, but RPR is still quite a bit lower at only 82.5%. So I just want to underscore the point that RPR sensitivity is definitely inferior to some of the newer treponemal-based technologies such as ELISA and chemiluminescence. And then shown here is the chemiluminescent treponema, just showing that it reduces the load of false positive results, especially in obstetrics patients. And so these set of data are nice because you can see head-to-head that the performance of chemiluminescence is actually very similar to the performance of TPPA, so pallidum particle agglutination assay. So that's a good kind of confirmatory result. But you can see that even in the normal group already, there's a little bit of a drop of RPR, let's say 97% versus 100 or 99. But in cases of autoimmunity, like ANA positive samples, the performance of RPR is 80, the specificity is only 87.5% versus 100% by either TPPA or chemiluminescence. And again, this is due to the fact that RPR is detecting cardiolipin, and this may be secreted by damaged host tissues in response to a number of other medical conditions, not specifically syphilis. So looking at mononucleosis, commonly induced by Epstein-Barr virus. The specificity of RPR was 90% versus 100 for chemiluminescence or TPPA. Lyme's disease, actually, that's another spirochete. So that is important, in terms of thinking about specificity, that we want to make sure that this test is looking at syphilis, that you're not looking at or detecting Borrelia burgdorferi. And so it performs well there, all three of the assays. But then in pregnancy, and again, if you're looking at how to screen for syphilis in pregnant women where the prevalence is really low, you really want a highly specific assay. And so at least in this cohort in patients, which is over 2,500, published in 2005, you can see the specificity of RPR was only 80% versus 100% for either TPPA or chemiluminescence. So I think this really drives home the point that although RPR is still an excellent tool for monitoring active infection in terms of a screen, it does have its limitations because it is not as sensitive as shown in the previous by the data in the previous slide, and it's also not as specific as shown by the data here. Okay. So just wrapping up here with the last few slides of some performance data. So one of our largest and most prestigious labs running the liaison chemiluminescent chemistry in the reverse algorithm format is Kaiser Berkeley in California, and they showed improved assay performance to RPR. So this is again looking at so chemiluminescence versus RPR is that first stage screening test. And as a couple slides ago, as we observed, so disregarding stage of infection, things like that, just looking blindly, RPR sensitivity was 73% versus chemiluminescent sensitivity was 100%. The positive predictive value, so the likelihood that if the patient has a positive result that it is indeed being caused by T. pallidum, that positive predictive value was 93% for chemiluminescence and only 72% for RPR. And then clinical specificity, again, was almost 100% for chemiluminescence versus only 94% for RPR. And again, this is not surprising. Looking at the previous slide with the different medical indications that might be causing a false positive result. So, and then the negative predictive value, so the likelihood that if you get a negative result, the patient does not have the disease, that is actually very good for both tests. So, if a patient is resulted out with a negative RPR, he or she can be pretty confident that that is indeed negative, assuming he or she, they can be pretty confident that it is indeed negative. Okay, so just wrapping up here, one final comparison table. Oops, excuse me. So, one final comparison table. So the other main T. pallidum specific automated assay available on the U.S. market is via the Bioplex from Bio-Rad. And so just looking head-to-head at some comparison, Dr. Lee, he works at a reference laboratory in Paris. And so he did a comparison with 392 samples. So looking at the sera in an unselected format, so CLIA Treponema IgG IgM shows improved sensitivity over IgG-only serology. So, so looking specifically at primary syphilis, because Liaison detects IgG and IgM, whereas the Bio-Rad assay detects only IgG, there are a few samples that would have been missed by this algorithm because the Bioplex or the Bio-Rad IgM assay is only cleared in CE marked and not 510K cleared for use in diagnosing syphilis in the US. And so just a little bit more specifically on that, so you can see that so for these 7 patients that were in the primary syphilis out of 392, these 7 patients were all detected as positive by Liaison and also by looking at a number of different antigens by Western blot, could be confirmed positive, and looking at a combination of bioplex G and M would be positive, but looking only at the G, there are a couple patients that would have been missed by this testing algorithm. And of course, I would love to repeat this with more patients in a larger study, but it is just an important note to make. And then finally, just understanding that the treponemal screening algorithm, or the reverse algorithm, can be automated, and this can reduce labor cost and increase throughput. So, regardless of what kind of automated instrument is used, any kind of fully automated random access solution would address a number of workflow issues, especially in a large reference laboratory, such as manual subjectivity, laboratory information system connectivity, interruption errors, and repetitive motion injuries, which again, I've heard several accounts of this being an issue with medical technologists that have to process a lot of RPRs. So something to keep in mind, how automation can really help with workflow and prevent the laboratory from having to do additional testing or be delayed in reporting out patient results. So now we're wrapping up. One of the favorite parts of my job is I get to facilitate collaborations with key opinion leaders all over the country and conduct clinical studies. So some ideas that I think would really benefit the literature would include comparing the positive predictive value of treponemal to traditional testing algorithms in select populations, especially pregnant women. You might recall from one of the slides that the positive predictive values between chemiluminescence and RPR was really different. The negative predictive value, not so much, but really understanding the performance of these two assays in the positive predictive value, I think would be really interesting. And then also comparing the false positive rates of RPR versus treponema screening in a population with a high prevalence of syphilis, and also looking, although I'm a scientist by training, but also comparing the cost effectiveness of treponemal to traditional testing algorithms in hospitals versus, let's say, smaller labs like a point of care lab. I think all of these would be really interesting avenues to pursue. And then finally, just revisiting our learning objectives for today. So, three methods for diagnosing syphilis infection. So I have it actually grouped into 3 bullets here, so you can, that's kind of a take-home message in itself too, that so dark field microscopy, or let's say molecular testing, might be the present day way to detect like an actual causative agent, detect the treponeme T pallidum from a site like a chancre. And then another kind of camp of syphilis tests include the non-treponemal tests, of course, RPR, VDRL, which are detecting IgG and IgM against cardiolipin. And then treponemal test is the last camp, so including like the agglutination assay, ELISA-based chemistries, chemiluminescence-based chemistries, and depending on the assay, it may detect G or M. Our chemiluminescence detects G and M. And I believe the agglutination assays do too. And then comparing and contrasting the 2 algorithms that are used in the diagnosis of syphilis. So the traditional algorithm may be suitable for a low volume lab and clinics serving patients with ongoing infection or high prevalence rates, but the sensitivity is low when you're screening with the RPR, and the method is very, very manual. Whereas the treponemal algorithm allows for automated testing if the laboratory so chooses. I mean, if it's a very low volume lab, you know, definitely you could still stick with a smaller plate or something like that. But in any case, it does allow for automated testing and enhanced sensitivity and specificity, looking at the performance of even our predicate device CAPTIA versus RPR. And it's ideal for high volume labs, especially screening for pregnant women where the prevalence is low, etc. And then name 3 benefits of the treponemal-specific IgG-IgM assay in identification and diagnosis of syphilis. So this allows you to detect primary syphilis 2 weeks earlier with IgG-IgM alone versus IgG-IgM together versus IgG alone. And then being able to detect primary syphilis 5 to 6 weeks earlier with chemiluminescence than with RPR. And finally, fewer false positives, obligating less confirmatory testing when you're screening with a specific T pallidum specific test like a G&M for treponema versus a G only. And I believe this concludes our talk for today. So now we will go through the question and answers that have been submitted through the chat box. And we have a good, just under 15 minutes to address these questions. Thank you.
Thank you, Dr. MacKenzie. As Dr. MacKenzie said, we do have a few minutes for some questions and answers. It does appear that we do have a couple of questions. The first question, in the assay design you showed earlier, you listed only one antigen. Some antigens that are available use multiple antigens. Is there a benefit for using only one antigen over using multiple antigens?
Yes, that is a, well, okay, maybe that's not the answer to the question, but yes, I understand your question, and that is a question that is always a concern in the diagnostics industry in terms of assay design. You know, how many antigens do you look at? Do you look at 1? Do you look at a cocktail of 5? You know, you really have to test each individual scenario. And so in the development of our chemiluminescent test, at least, I have right here the development from our product support team, product development team. And so we did look at P15, P17, and also P47. And you recall from the little cartoon that I went through earlier that we chose only the P17. And that is because it is the most reactive antigen for antibodies to T pallidum. And from testing in the development of this product, it did not, you know, looking at the cocktail of the 3, P15, 17, and 47 versus 17 alone, it did not, you know, the trio did not offer any added sensitivity or specificity. And actually, risk, kind of the philosophy in general is that the more antigens that you look at, you have to always weigh. Maybe you are getting a little bit better sensitivity, but then the more antigens you look at, the more likely you are to decrease your specificity. So, and then also in the performance of our assay, we were comparing to a ELISA-based chemistry from Germany at the time, because this was developed in Europe, and both assays were looking at 174 samples, and each one only misdiagnosed one sample, a different sample, so each product. So, you know, the performance was equivalent between looking at P17 alone versus P15, 17, and 47 together. So that's why in the development of our assay, we went with just the one antigen. But excellent question.
Our next question, are there any molecular tests that are available for syphilis? Would they be a better option for screening?
So yes, this is also a question I've been asked by pathologists practicing. I was out in Washington at the Washington Department of Health and some other regional core labs there. And yes, and it's something also for me, from a molecular background, I'm also curious where the molecular testing fits in the picture with diagnosing for syphilis. So, and then in response to that, there is a key opinion leader at University of Washington, Dr. Sheila L.A. Lukehart. So I pulled a couple of her very nice publications from the late 90s, early 2000s, and her group has established, you know, a very nice molecular test that can detect down to 1 treponeme, you know, in a sample, and she also looked quite a bit at cerebral spinal fluid, and so yes, there are molecular tests available, and for doing something like being able to investigate a specific lesion, a specific chancre, if you want to be able to do a swab and be able to result out, is this specific lesion being caused by the treponeme T pallidum? I think, you know, that could be a really exciting area for molecular testing to play. But for screening, still, molecular testing is not, at least as of right now, I do not see the evidence that it's going to replace serological screening. I was also speaking with Dr. Khalil Gahim from an MD PhD from Johns Hopkins at the CDC conference, and it just doesn't look like there's the studies are there yet showing the amount of treponemes that are positive in the sera as compared to IgM response. So I mean, it may be available as a confirmatory test, but in terms of screening, again, once a patient is positive for T pallidum, that G is positive for life, and then that M is positive right away. So you really have the sensitivity and specificity right there. But definitely in terms of replacing dark field microscopy and fluorescence detection of T pallidum for a specific chancre, I think that could be an excellent place for molecular testing to play a role. It'll be exciting to see if some of those come on the market and become 510K cleared in the near future. So.
Okay, there is one more question. There are a number of rapid syphilis tests that are becoming available. Do you think these would have a utility in the clinical laboratory?
That is also an excellent test, and yeah. So at this CDC STD conference we were at a couple of weeks ago, definitely in the third world. So speaking kind of from more of a Bill and Melinda Gates public health sort of perspective, rapid testing is an excellent option. Just if it's impossible for midwives in Peru to be able to gather serum samples and keep them cold and transport them across the country, rapid testing, for syphilis or HIV is really exciting, and it was really great to see that. But in the U.S. also, I came across a poster at this conference. So it was actually looking at populations where syphilis was highly prevalent, and they were still arguing for the reverse algorithm, advantages of the reverse algorithm. So screening with a treponemal-specific test, I believe they were using an ELISA, and then confirming with something like RPR. And this group was saying that that perhaps a way to confirm immediately, because so if the patient is positive for G, and you want to determine if that positivity is due to a past infection or a current infection, and you get let's say you get a positive RPR. These rapid tests, let's say you get a negative RPR. These rapid tests would be a great way to just immediately confirm or deny that testing algorithm. So actually, the rapid test in this case would possibly replace the RPR. But so again, I'm not 100% convinced. We'd have to do some cost effectiveness studies to show if you'd really want to screen with the rapid test, just because that might be a lot of plastic and manual labor if it's not automated on an instrument. But in terms of confirmatory, so following the screen, and you want to immediately, these rapid tests they're made for point of care testing, but I think they could have a clinical utility in some of the larger labs as well for just a quick yes or no answer in terms of confirmation, but in a lower volume than the screening. So yes, I think it could be playing a role, and I think more and more are becoming 510K cleared, if I'm not mistaken. So.
Okay, I think that's it for our questions. Once again, thank you, Dr. MacKenzie. As a reminder, don't forget to register for your CE credits by clicking on the CE image in the lower left hand of the speaker page. Thank you for attending today's webinar.
Thank you very much.